Thank you, Dr. Atif. Excellent talk. And I'll just tell you on my experience, I wasn't happy with MGB and mostly I was doing sleeve and SASI. But last, I think almost in 5, 6 months, I've done almost 50 MGB and we've done like 6 super obese patients. And I think you're right. If you properly prepare these patients, you can go for a primary procedure as a single procedure, OHB or MGB in those, and they are doing excellent. And now we are running short of time. We are just pleased to have Dr. Javiad Raza from Cleveland Clinic, Dubai. He's the director of bariatric surgery there, and I'm really honored to have him in this live session. He will talk about complications of bariatric surgery. Yes, Dr. Javiad Raza, mic to you.
Assalamu alaikum, Maaz, Atif, and everyone in Pakistan. It is a pleasure to actually communicate with our friends, which I have not done for almost a year. And I hope everyone is safe and looking after themselves. And Maaz, thank you for inviting me to participate in this wonderful activity. The program is fantastic. Unfortunately, I'm operating today, so I won't be able to join for the whole part, but I would love to listen to the recording if that becomes available. So I hope you can hear me well. If someone can indicate so that I can carry on.
Yes, you can carry on. We can hear you.
Okay, thank you. So I thought rather than going through the textbook, early league, late league, and things that everyone can read, I would go through my journey of how over the last 10, 15 years, I have dealt with leaks in different bariatric surgery procedures, and maybe there are some lessons in that. I had very limited experience of dealing with leak when I was in UK. Primarily, it was my own service and complications, but since I've been in Cleveland Clinic, Abu Dhabi, we are the referral center. So the experience has very significantly increased, and thankfully, not from our own complications. We are doing more things and learning more. So this was my patient in 2009, a 24-year-old, BMI of 60, 200 kilogram. He worked as a bouncer in a nightclub, no comorbidities, and he came for a routine sleeve gastrectomy. It was a technically slightly challenging operation because of large liver, but went well. Post-op day 2, he went home as routine. Came back to the emergency department post-op day 5 with abdominal pain. He had a forceful vomiting after he attempted to eat a burger. That was post-op day 5. We could not get him into the CT scanner at that time. So the option was to either treat him conservatively or do something about it. So conservatively could be that, yes, you give him antibiotics, you hope that he would settle, and if he doesn't settle, then you go back in and see what's going on. And that may be the situation in some of the practices in Pakistan where availability of CT scanner may not be in smaller centers, it may not be possible. So I decided to do a laparoscopy. There was no collection, actually. There was no leak demonstrated. So it was a suspected leak, but the patient had fever, tachycardia, although he did not have respiratory symptoms. But any post-op patient, especially a 200 kilogram man, the window to treat and keep the patient stable is very short, and unless you take action, a negative laparoscopy, you don't lose much. But if you lose time, and if this patient becomes septic or hemodynamically unstable, then it would be very difficult to look after this patient. So anyway, We did an endoscopy at the time, and we did not demonstrate a leak. I did a methylene blue test. I inserted a nasogastric tube, which the patient did not tolerate, and pulled it out next day. We then convinced the patient to have a softer. The first tube that was available in the OR was the regular tube, which is stiff, and he did not like it in his nose. So we scoped him again, did a fine bore softer tube, and put it into the duodenum. And he stayed in the hospital for a few days, and then went home. And the plan was to keep the tube in for a few weeks and then do a contrast study, which was a fluoroscopy type of upper GI contrast study. But he, I think, pulled the tube out, and fortunately he got better. So that was the end of that leak or suspected leak right at the beginning in 2009. And we may come across similar scenarios where you suspect a leak. And my advice to especially our juniors, trainees and junior surgeons is, although in private practice it is difficult, but resist the temptation and don't just hope that it will get better. It is always advisable to be aggressive, especially at the beginning when you are alone in your service. The second patient, I started doing hands-on, and first 185 cases went well without leak. We were presenting in Barcelona in a European IFSO chapter, and I was very happy sitting there, and my registrar was presenting those zero leak in 185 patients. And that evening I had a phone call from Derby that the patient that I'd operated 2 days ago, the previous week, came back with abdominal pain suggestive of a leak. So again, I think bariatric surgery is a very humbling profession, and just when you start feeling good about yourself and think you've done it, then it sort of reminds you that complications can and will come and will affect all of us. We cannot 100% avoid them, but if we have a plan and a strategy to deal with them, then hopefully we will not cause long-term harm to our patients. So this patient readmitted with fever, abdominal pain. CT did not demonstrate a big leak, but it confirmed a collection near the spleen. So there was no contrast leaking out from the stomach, but and the patient had left-sided pleural effusion. White cell count was around 14, CRP around 90. Patient was not sort of tachycardic, or tachycardia was around 96. So it was not a moribund septic patient. But I decided to do a laparoscopy washout, and this time I used a soft tube and put 2 abdominal drains. The patient stayed in the hospital for 2 weeks, and he went home with the drains and with NJ feed for another 4 weeks. Contrast study showed that the collections had gone. There was no leak demonstrated. We removed the drains and we removed the NG tube, and fortunately patient got better. So these were the sort of simpler, luckier incidences in sleeve and a bypass. And then the next 2 patients are in our Cleveland practice. So patient number 3 had all basic surgeries done in Alain at an outside hospital. 31-year-old man had a mini gastric bypass 2 years ago, and unfortunately had severe malnutrition. His BMI is about 18 now, and reflux symptoms. So the surgeon in outside facility decided to reverse him and reverse his anatomy because the patient did not want any other operations. So the patient had a reversal to normal anatomy and was discharged home on post-op day 1 after a normal upper GI contrast study, and I've put it into red because a patient who's malnourished, and I asked the patient when he finally came to us, the patient did not have any significant nutritional preparation beforehand. No TPN, no J feeding tube, and one would expect that with that BMI of 18, the patient is malnourished. I don't know what the pre-albumin and albumin was for that patient, but this was obviously a high-risk patient. And after reversal of anatomy, you would not discharge. I would be tempted not to send this patient home this soon. Not surprisingly, the patient was readmitted on post-op day 2 with fever and abdominal pain. His CT showed a very visible leak where the contrast was leaking from the GG anastomosis, where the gastric remnant was connected to the gastric pouch. It had leaked and there was frank fluid in all quadrants of the abdomen. So this was post-op day 2. Post-op day 3, they performed a diagnostic laparoscopy and put an omental patch at the leak site. Patient transferred to ICU, PICC line was inserted, TPN was started. Post-op day 5, the patient remained on antibiotics in ICU. Post-op day 5, they invited the gastroenterologist in the hospital to perform an endoscopy in the ICU. And this endoscopy actually showed that there was a stenosis, and this is according to their description, where the bottom of the previous pouch was. So according to the surgeon, at the time of creation of mini gastric bypass, they probably had gone too close to the greater curvature and made that area narrow. And the anastomosis between stomach and gastric remnant and pouch was proximal to it. So obviously there was a distal narrowing or obstruction, and that might have resulted in leak along with the malnutrition of the patient. So they dilated that narrowed area and then placed a fully covered stent in that dilatation and to cover the leak. This was post-op day 5. Post-op day 6, patient had increased abdominal distension, pain, had a further CT scan, and also received some blood transfusions. And the following day, post-op day 7, he had a laparoscopy. During laparoscopy, unfortunately, there was an injury to the transverse colon. So we ended up having a laparotomy, washout. The gastric anastomosis, which was used for the reversal, was excised, and a new anastomosis was created, and the transverse colonic injury was repaired, and the stent, the previously inserted stent, obviously was removed before the surgery. The patient also had an appendicectomy, I think probably prophylactic, and multiple 4 drains inserted. Post-op day 8, CT did not reveal any leak. Bilateral pleural effusions, as one would expect. Interventional radiology were invited to drain these spaces. Now, I've gone into a little bit of detail to sort of inform you that when you have resources in the system, how multiple specialties can help you to deal with these patients. And I tell you, when you have a leak from one of your own patients, it's a very lonely place as a bariatric surgeon. And for that, I would say that it's important that you either work as teams to share this burden, and or have someone that you trust, that you regularly communicate either in your hospital or in your city or in your country or outside the country, with whom you can share this. And sometimes it's important to step away from the patient, look at the bigger picture, and make logical decisions rather than emotional decisions. And that's why it's very, I think I'm delighted that in Pakistan, we have this wonderful network of bariatric surgeons. And I'm sure any of you can communicate to any other surgeon. Certainly, there are a lot of us abroad, and if there's ever a need for discussion, we're always available, most of us anyway. So post-op day 13, the patient had a wound dehiscence, so had a further laparotomy, wound exploration, washout, and sort of a partial closure of the wound. So this is, I'm sorry, my top of the screen is covered, so I'll see if I can move it. So this is post-op day 18. The patient was transferred to us. And the patient, we did a CT. When the patient came, there was no definite evidence of contrast on the CT that we did here. We saw 4 drains, minimal free fluid in the tummy. And the main collection was where we expect was, I would say more than 90% of the patients who have a leak after bariatric surgery would collect to the left of the gastroesophageal junction going towards the spleen, and almost everyone will have a pleural effusion. And in some patients in leak, where there may not be other very visible or evident signs, if there is a pleural effusion on a post-op bariatric surgery patient, suspect there is a leak until you can prove otherwise. So I decided, so this is a patient that I treated. So I decided to do an endoscopy, and at the endoscopy on the picture, this is the gastrogastric anastomosis. Gastric anastomosis, and the exit of the stomach is to the right of this. So we decided to, I did a contrast injection during the endoscopy, and it showed a definite leak. So we do this endoscopy under fluoroscopic guidance. So we have X-ray and endoscopy in the same room. And on the contrast, then with skin clips, we marked and we went into the duodenum. So this is the distal part of the partially covered stent. And then I did a contrast following the stent insertion, and there was no leak after this. Post-op day 22, or 2 days after the insertion of the stent, we did a formal fluoroscopy in the department. And it is important to do that after insertion of stents, because stents can move. And it did move, so it slipped back a little bit, which meant that the distal end of the stent fell back into the stomach, which also meant that the fluid and juices could go around the stent and go through the leak again. So I took this patient back to the endoscopy and tried to move this stent, but it would not cover both ends. So I put a stent within a stent where the distal part was in the duodenum. Post-op day 31, which was a week after the second endoscopy, I went to remove these stents. We normally can keep them for 2 weeks if they are in the stomach and the esophagus, but the distal end of this stent was in the duodenum, and I did not want to cause an erosion of the duodenum. So we went back, took both the stents out, did a contrast, and there was no leak. So we then did not do any further intervention. We allowed the patient to have sips of water, did a further formal fluoroscopy. Patient did not have leak, and then he's gradually progressed to soft and now full diet. And our malnutrition expert is now waiting for his permission before he thinks the patient is taking enough nutrition by mouth that he can go home safely. And I've got one more. So this is again a complex patient who had a sleeve gastrectomy in an outside hospital in November and was discharged post-op day 1. Post-op day 5, he presented to the same hospital with fever, tachycardia, and abdominal pain. He had a CT scan which showed leakage of the contrast from the proximal posterior stomach, and there was free fluid in all 4 quadrants. So he then, following that, on post-op day 5, he underwent laparoscopy, drainage of intra-abdominal collections, went to ICU, and antibiotics. He had stayed there, and post-op day 10, he had a fluoroscopy which showed a leak in the proximal stomach. At this point, the patient and the family wanted a transfer, and the hospital requested us to take over the patient. So the patient came to us, and post-op day 10, there was frank, the CT that we did here showed a lot of fluid collections. Excuse me. Osman, I'm in the conference and doing the talk. I'm holding your call. Sorry, the life goes on in the hospital. So then we decided to do the endoscopy, and on the endoscopy, there was this on, I hope you can see it, on the left side, you can see there's almost a recess with a staple line running here. So this was the redundant fundus, and the leak was within that. So we then placed an esophageal stent to cover this, and the post-stent contrast on table did not show a leak. And these were the images. The leak was somewhere up here. And we placed 3 clips, one at the gastroesophageal junction, one at the gastric exit on the skin, and this guides us when we are inserting the stent. So this is post-op day 12. 2 days after this stent, we did a fluoroscopy that showed the contrast was leaking around the stent, and it was coming out and going around and leaking from here. Patient was in ICU and was septic, so we decided to take the patient to the operating room. Started with laparoscopy, but it was evident it was not going to work, so the patient had a laparotomy post-op day 13 from original operation, and extensive adhesions, infected fluid. We did an endoscopy, and there was no air leak. We did a methylene blue test. It did not show a leak. So it was only when we do a formal fluoroscopy, that's when this leak became evident. So one of the lessons is that during surgery, when you take the patient back, if you don't find a leak or if you cannot demonstrate a leak, it does not mean that the patient does not have a leak. Simply means we have not demonstrated that leak. So we placed further drains or reinforced the drains or repositioned them. And then 2 days down the line, second look, there were no abscesses. The stents was readjusted because it had moved. And at this point, the abdomen was closed because the abdomen was open for nearly a week by this stage. The patient had raised intra-abdominal pressure, and we felt that the decision to close was not the most appropriate for this patient. So he needed to go back, wash out, and then an Apthera, which is an open abdominal management system. And then the patient was in ICU, antibiotics, TPN, and just management of the drains and a family which is very anxious. This is post-op day 28. Further, we went in and removed the esophageal stent, and by this stage, the opening had remained very small, but there was still a leak that we could see on this. So this time we decided to put a sort of a biliary type of drain in that hole to drain the cavity which is sitting outside the stomach. And so this is the guide wire, and these are the images of the final JJ stent. We also inserted a nasoduodenal NJ feeding tube as well to support the nutrition of the patient. So the post-op day 32, the story continues. The abdomen was open, so we decided to put a sort of biological mesh just to manage the abdomen better. And the patient also had a tracheostomy because he obviously was going to require longer care. Post-op day 40, again, the CT scan did not show any ongoing, but it just simply tells you for a very sick patient who has been very sick for a long time, there are a number of things that come up and you have to look after all those. Lungs, pericardial effusion, pleural effusions, antibiotics, IR is involved, infectious disease is involved, nutrition is involved, rehabilitation is involved. Post-op day 50, the patient comes out of ICU after 45 days in ICU. And now the leak has healed. We replaced the double J stent. The further contrast showed a very localized small collection. And now the patient is eating and drinking. He has an abdominal binder for the potential hernia that he has. And vac dressings, neurology has been consulted because he's developed weakness in the hands. Post-op day 70, now he's ready to sort of start thinking about home. So these are the different aspects that we are, this is one of our resident and his note that I've put here. He's looking at different aspects of this patient. So nutrition, abdominal wound, right hand pain, hospital medicine, neurology, vascular surgery, everyone involved in the care of this patient. So from a very simple and lucky episode where they have mild symptoms, you go do laparoscopy, don't find much, they get better, to someone who would almost die without a multidisciplinary team with a lot of resources. So my message or conclusion is that any bariatric patient who is not behaving the way you expect them to behave, then please suspect a leak and treat it aggressively and prove that it's not a leak. Ask for help from your colleagues, from people around you, from your colleagues in other cities, abroad, wherever there is advice. And I think we have a wonderful atmosphere in bariatric surgery in Pakistan that people are willing to help. And I would very much encourage this, this culture of discussion. Nutrition is the key right from the start. And then if the nutrition can be within the gut, that is ideal, either through the nose or through a separate tube. And I know in private practice, the patients have just enough money to pay for staplers, and you have to think, what am I going to do? So all the fancy things that I've shown are not possible and practical, and I understand that. But that's why it's very important to go early with an intervention according to your resources, but think that there's a patient on the other side. And you have to think of them as if they were your relative, what would you do? And if you have to send that patient to another colleague, then swallow your pride and do that. So the complications of bariatric surgery will keep on happening to all of us. And I think we need to keep learning and evolving to look after our patients as well as we can. with that, I will stop. Thank you very much.
Thank you very much, and so nice of you, Dr. Javed. Excellent elaboration of gastric leak and regarding all bariatric procedures. And we always take help, and you are very helpful. Whenever I call and when I need you, you're always there. So nice of you. Kindly join in our panel discussion also. So we have got questions also, and in the end, we like
I
you.
would love to, as I said, I'm operating today.
Okay.
If it clashed with the time when I'm in the middle of something, then my apologies in advance. But I look forward to, because I've not seen a lot of our colleagues and friends and seniors for a long time. So I'm looking forward to that opportunity. And once again, thank you for inviting me to participate.